You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. This episode's guest is Troy Trygstad, Executive Director of Community Pharmacy Enhanced Services Networks, or CPESN. Mr. Trygstad holds degrees in health economics and pharmacy policy and is focused on value-based care, clinical integration, and innovation for much of his career. He speaks with host Ken Kleinberg and Pooja Babbrah about how pharmacy is evolving to support the value-based care model, including how pharmacies need to be paid differently and establishing what a pharmacy value-based contract might even look like. We hope listening to this episode was helpful and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Hello, everyone, and welcome to The Dish on Health IT, where we break down and discuss some of Health IT's biggest news and most exciting milestones with leading industry guests. We at Point of Care Partners are Health IT consultants who work with stakeholders across the healthcare ecosystem, and we're viewed as an independent, trusted party. I'm Ken Kleinberg, practice lead for innovative technologies, and your host. My colleague and co-host, Pooja Babbrah, and I are excited to welcome our special guest, Troy Trygstad, Executive Director of CPESN, that is Community Pharmacy Enhanced Services Networks. The key topic we'll be discussing today, the role of pharmacies and how they're evolving as a key part of the healthcare value chain. But before we jump into the discussion, I'd like to have my colleague and co-host briefly introduce herself, tell us what excites her about today's podcast, and congrats, Pooja, for being recently named as Vice Chair of the NCPDP Board.
Great, thanks, Ken. So Pooja Babbrah, I'm the PBM and Pharmacy Practice Lead for Point of Care Partners. And yeah, I'm pretty excited to take on the Vice Chair role at NCPDP. You know, there's so much happening right now in pharmacy and around pharmacy standards, interoperability, and just being able to support the shift from fee-for-service to value-based care. And that's really what I'm excited to have Troy here to talk about that today. You know, he's been kind of in the middle of all this with the community pharmacy work and the e-care plan. So really excited to have Troy as our guest. Ken, you know, I'm always trying to push pharmacy on this podcast. So I'm excited to have an episode dedicated to pharmacy and the support of value-based care.
Okay, great. So let's greet our guest, Troy Trygstad, Executive Director of CPESN USA. Troy, welcome to The Dish on Health IT. To start, could you tell us a bit about yourself? And for those who are not familiar, tell us about CPESN.
Sure. Well, thanks for having me, Pooja and Ken. I come from a small town in Iowa. I went to pharmacy school in Iowa, and I moved to North Carolina to do a graduate program in health economics and pharmacy policy. And that led to 15 years with primary care, trying to figure out how to do accountable care, clinical integration, meet value-based contracting with purchasers and grants and innovations and the state and commercial payers. And one day somebody said, we want you to go try and do that with pharmacies. And so here I am 4 or so years later, and in many ways feel very blessed because it was a great trajectory, because all that sort of learnings on what's going on the medical side that happened 10 or 15 years before it's now happening in pharmacy. There's a lot to draw on, good, bad, or ugly. And so what ended up happening was creating basically the same version from a regulatory infrastructure, data, operations posture in pharmacy as you would see over on a medical clinically integrated network.
Okay, so let's get into the issues at the high level to start. How do you see the role of pharmacies evolving to meet the needs of value-based care?
I don't think it's anything new. I think leaders within pharmacy have been saying it for 30 years. Hey, you know, in fact, I'll use a medical side example. The first mention of patient-centered medical home was from the American Academy of Pediatrics in 1967. But the first medical side ACO, value-based contract, or PCMH activities really didn't ramp up until, after the first of the century, right? The turn of the century. So just like 3 decades of pharmacy leadership saying, hey, you need to change, you need to get to outcomes. You need to be holistic. You need to collect data differently, contract differently. The same thing happened on the medical side with primary care. Their leadership's been yelling at them, but it really took market dynamics, payment reform, alternative payment models, coming from a purchaser marketplace of consumers, taxpayers, and employers saying we've had enough, that actually stimulated it to action. And now, people are still relying on fee-for-service largely, but you can't be fee-for-service exclusively anymore. The tide has started to turn where you have to participate in value-based contracting to be viable on primary care. Well, that was prompted by a market change. And my belief is that market change is happening in pharmacy now. So, telling somebody they need to change when they're healthy and making money and they're sustainable is much harder than when they have their first heart attack or they get some bad news on their A1C. And now there's a lot of patient pharmacies out there that know the end is near unless I actually change. So I'll often say that we have more pharmacies ready to quit smoking than have ever been ready to quit smoking. And we need to figure out a way to help them quit smoking and get reimbursed for it, right?
All right, thanks, Troy. Pooja, as a pharmacy expert, what are your thoughts about Troy's points, and how do you see pharmacy and the medical segments learning from each other?
Yeah, I agree with everything Troy said. And, we had done kind of this model around value-based care and the different stages of adoption. And when I think about kind of the early stages of value-based care adoption, it's really around linking kind of fee-for-service to quality and value. And I think we saw some early kind of examples around that in the pharmacy and PBM space. CVS, I think a few years ago, put out this kind of, they called it the value-based formulary, right? And it was supposed to be around kind of this concept of using the drugs that would provide the best outcomes. I don't think there was much adoption around it, and it was kind of early. But now I think you're starting to see a shift, right? Where we're starting to actually see the value-based contracting, the manufacturers, the PBMs trying to say, how do we make sure that we're using medications that you're going to actually see the outcomes. And I think part of the problem is there's just no way to measure that kind of stuff. So then we have to look at the pharmacies, and I think the pharmacies and the pharmacists can actually directly impact outcomes, right? That smoking cessation, they can play out that front role. They can be working with their patients that they're seeing when they're picking up their medications. And I think, starting with the pharmacists and the pharmacies are the right way to bring in more of that tying reimbursement to outcomes. We just need to have models out there to be able to do that. And we're not quite there yet, I think, on the pharmacy side, unfortunately.
Yeah, I think another, shorthand way of saying it is, what's passed for medical is becoming prologue for pharmacy.
Yeah, absolutely. Yep.
Yeah. All right. Well, let's turn our attention more specifically to what CPESN does, and, for example, with e-care plans, helping the industry with identifying gaps and improving communications, focusing on quality. Could you tell us about that?
Yeah, I think that I would go back to a seminal moment in my life, my career, very memorable. It's one of those, where were you when this happened? For me personally, I remember the desk I was at, where I was at, the time of day. It was we were in our first year of this CMMI Innovations Award that was provided to integrate interprofessionally and with care processes with primary care, and then pay the pharmacies differently. What does a value-based contract look like even? And how would it get implemented in the medical neighborhood was the basic question that CMMI was asking. And so we thought, hey, this is awesome. We've got this sophisticated 2,500 practice PCMH entity called Community Care of North Carolina. They've got a elaborate informatics center with care management systems that have all this access to data, notes from the home, hospitalizations, twice daily event notification, ADTs from hospitals. I'm a pharmacist. I've got all this stuff in there. And we got through a year of the project, and one of the what we call luminaries leaders said, Troy, if you don't figure out how to get us out of that system, we're going to quit the project. And I said, well, now hold on, right? What's going on? He said, it's completely and absolutely impossible for our workflow. And I know well enough to know that when providers say X and you want to make sure providers can change, you listen. And so we literally did a 180-degree turn that moment in the program and said, okay, we're moving away from a system that they're logging into to a system that of standards to work with the systems that they live in the pharmacy of their choice. And so that led to a call to CMS and ONC and a high impact pilot where we said, we're going to be looking for a standard to figure out how you share clinical information in and out of a native community pharmacy's system of record. That led to a whole project of 18 vendors that serve at least 20,000 pharmacies out there, up to and including chains if they want to. Some of them are native pharmacy management systems. Some of those are more portal-oriented, just like e-prescribing. We don't care. We just need the transaction, right? Give me the script standard. I know what I need to receive over here so I can engage in these value-based arrangements and data sharing. And so we did that as part of the CMMI effort. And that changed the project fundamentally. And here we sit today, and there's millions of care plans that now transact under the HL7 Pharmacist Electronic Care Plan Standard. It's not great for claims adjudication. I just got off a call where what we're trying to do is set up a system through telecom for billing and a system through care plans in order to collect the clinical data that you need for performance and those types of things. And so from my perspective, I'm very bullish on the electronic care plan, but we don't have the super highway and the bells and the whistles and the sidecar utilities for fee-for-service billing and those types of things to go with it. And so, I guess I'll finish by saying why I'm so bullish on the care plan. I think people that are skeptical of it will say, well, it's a CPESN thing. No, it's an HL7 thing, and it's balloted all the way to the same place as CCD, which is written into meaningful use and bonuses. So the standard works just fine, and it's got a heck of a payload. Well, yeah, but we just want A1C and FHIR is more simple. Great, it's FHIR compliant. Well, what we really need is drug therapy problems closed, labs, and vitals, and we don't need all this other stuff. Well, you just described the care plan, right? So, if you want to use something else, I'm cool with it. I could care less, right? But if I can get all the information in one transaction, then I need to do pretty much whatever I need to do from care coordination or submitting data to a plan or whatever else. I'm going to use that till something else comes along.
Yeah. Pooja, what are your thoughts about these care plans, these e-care plans? Is there a lack of awareness and a lack of use of them?
Yeah, it's interesting because I agree with Troy. I think it does have everything that people would want and need. And of course, we've have this all the time, this discussion all the time with, HL7 FHIR. Now that's kind of the shiny new thing, right? So everyone's focused there and they're not kind of looking at what's in place today. And I think there was somewhat of a lack of awareness, although, just as I was preparing for this discussion, there's a lot of pharmacy systems, obviously, that have this wrapped in, and even the integration with the EHRs now. And, Dr. First, Epic, Cerner, Athena, Allscripts, they all have this capability. So I think, we need as an industry, I think we need to start talking about it more. And I think part of that's going to be driven by, just people understanding what's available in there, and also systems, right? Bringing the pharmacist in, because I think a lot of times, it's that partnership between the provider and the pharmacist and the community pharmacies that need to happen. But I think also the payer side, right? I mean, we're out talking to payers all the time, and I mentioned that this is available. And I think there's a lack of awareness, especially on the payer and the reimbursement side. And I think, once we start closing that loop, and being able to do some of that reimbursement and getting the payment, I think that's going to help a lot. I know for a fact ONC is actually looking at this as well around the adoption and things like that. And so I think, when I think about just being able to kind of get this out in the industry, I think, having it available, people understanding what's available in the transaction, and just, getting that support is really important. So.
Yeah, and I will say, interestingly enough, back when I was doing practice transformation supports in primary care, we used to often say, because we went through, I started in 2002, we went through kind of e-prescribing adoption and the MMA of 2003 kind of stuff that was incentivized there. Then we went through a high-tech ARA and adoption. And we used to, always say much easier to go from paper to EMR than to go from EMR to EMR.
Yeah.
Right?
Yep.
Similarly, I do think pharmacy can kind of get out ahead of this kind of clinical data. The reason we can get out ahead of it is because there is some advantage to getting into the game late. I'll give you, for instance, of the 18 vendors that produce care plans right now, or technology solution providers is probably the more appropriate term. Of the 18, 17 are FHIR. They're not CCDA, right? And so that tells you, like, hey, they're already got baked in now the ability to send an A1C over to here to Athena if they need to and want to. It's really more of a directory issue and user interface. A lot of times what we said when we set up in this project with High Impact, ONC, and Lantana, it was what we really like about the idea of saying this is the transaction is that the care plan says, here's the relevant information in the plan of care for today. The CCD is tell me what you know, EMR. The care plan says, tell me what I need to know, payer, value-based program, care coordinator, PCP, as far as the care coordination. The other big benefit was we knew going in and saying, hey, vendors, TSPs, adopt this, that if you got to the care plan standard, you couldn't half do it, right? Which means if I have vitals and labs and drug therapy problems, what do I have to have? I have to have a user interface where I can enter labs. I have to have a LOINC code lookup. I have to have a pick list. I have to have vitals user interface. I have to have a SNOMED library. So part of what we were also doing in the project was basically saying, if you can hit this standard, you're going to be ready on a whole bunch of other fronts. Right? It's more of a TSP and provider readiness exercise as well. Do I care if you only have A1C and you can only send A1C FHIR to some entity? That's great. What I know is that there's 18 TSPs that if those pharmacies are using those 18 TSPs, they have the range of capabilities. That's why this idea of meeting the standard, which I don't own, it's not CPESN's, mattered to us because we needed pharmacies that had the utilities to do this stuff to enter into these contracts. Up to and including, I have to be able to see and put an A1C in there. It's not just about the transaction. The real work is what do you need to be able to do in order to actually put that data point in that transaction and send it. The transaction part's the easy part, right?
Well, let's tease that apart for a moment. We're all bought in on FHIR, and the N in CPESN is network. How do you see the role of a national lookup, for example, and the ability to do patient matching have an influence here? And then if we had that, what about, and I think you were driving us toward that discussion here, how does this integrate with the workflow of pharmacists and other stakeholders?
Yeah, so early on in the project too, as we kind of got going, I would often tell the folks like Shelley and the PHIT Collaborative, we're going to flip the priorities and the sequencing of this on its head and flip it. Rightly so, I'm a provider of care as well. We often think, oh, we're going to share information because we're going to have a better picture of the patient. We're going to be able to provide better care delivery. No question that's nirvana and that's where we want to be. But you don't start with the hard thing first, ever. Start with the easy thing first, okay? So the first reason we collected is because we have an obligation from a regulatory perspective to collect clinical integration for the purposes of quality, improving quality, reducing variation. Well, that's on the easier pile, right? Because once you get the TSPs to do the standard, there's only one place they're sending it to start with. And we're just saying, does this meet the transaction or not? If not, kick it back to you. If it does, bring it in. It's all the same. So for us, it's all the same coming in. For them, that's standards, right? But you send it to one place. That's on the easier pile, then it's just analytics. The next step is to say, well, who can we share it with in a simple sharing, right? And that can be a university to figure out, hey, what preceptors are good about doing care plans and advancing those types. That's just analytics, a receiver that can use that for a good purpose. Payers, I'm shipping you information on an SFTP, simple use case, party to party. Next, more complicated, care managers, send it to you, MCO care managers, because now you have a system you can put it in. Care coordination, but point to point. Then we get to the hard stuff. And this is where it takes a community, right? It takes consultants, it takes ASAP, it takes PHIT, it takes NCPDP, it takes whoever, right? It takes ONC. When we're starting to talk about switchboards, we're in a whole nother level, right? Because it's not the transaction now. It's not the provider and the incentives to do the work if you've got that knocked out. It's not the valuableness of the information, because care plan's very salient, very timely. It's who am I working with? How do I load that directory in? What am I sending to whom for what purpose, referral, care coordination, or whatever? That's the hard part. And I think for a lot of people, they started with that. It's like you're starting with the most challenging thing first, right? Start with the simple thing first, right? And this is why, payers and value-based contracting, to me, are the vehicle that we get to care coordination, right? We don't start with care coordination for the sake of it, unfunded mandate. We say, hey, if this capability exists now, maybe we can figure out a way to pay for that coordination. Maybe we'll pay for CCM to the pharmacy if the pharmacy can send a care plan to Athena. You just said they got fired. That should be on the easy pile for the TSP, so long as there's a routing system to do that, or a universal lookup. So that's, I think, flipping it on its head, starting with the easy and getting to the hard was one of the things things I'm really glad we decided to do.
Pooja, what do you think?
Yeah, no, it's funny because I think back to my days when I was, doing the EHR, implementing meaningful use, and we were told, you have to incorporate these direct addresses, right, for physicians. And we're like, how are they going to know, like, if I want to send to another doctor, like, I don't know, your direct address. And I think of it the same way, right? I mean, to your point, if you're capturing the data, but who are you sending it to? How are you finding that person? And I think, all the discussion about the FHIR directories and everything that's happening around interoperability is a step forward on the medical side. But I think from the pharmacy side, I mean, clearly we need to be pharmacies should be included in those FHIR endpoint directories as they start getting rolled out. But I think having that, wrapping the value-based contract, the value-based, things between the providers and the pharmacies, and doing it within that context is really important. And I think, you're going to get some wins there. And I think after that, open it up, right? Once we solve, and I don't think we've even solved it, on the medical side around directories and finding, where to send information. So I think, I like, and I never realized this approach that you guys took around this. And I think, it's the right way to be thinking about it, wrap it into those value-based contracts that are existing. So you have that communication back and forth between those providers and those pharmacies. So
pharmacy, pharmacy never got MIPS, it never got MACRA,
exactly.
It didn't get high tech, it didn't get TCPI, it didn't get PTN,
Yep.
It didn't get any of those things. The only way we're going to get to that point is if there's a way to get to a business incentive that leads to a better A1C or a CCM. I can bill that now as long as I ship it to a primary care provider. I can bill that by myself. It doesn't have to be them, or it's a co-bill. There's going to have to be some sort of marketplace innovation financially in order for this to happen, absent some federal mandate, which I don't see coming in pharmacy because we've been passed over so many times. Why would we think it's going to happen anytime soon?
Well, let me ask you, Troy, on this topic of regulation, as I understand it, pharmacies are considered an actor for 21st century cures and information blocking. How do you see the focus in Washington as it relates to pharmacies and your goals?
How many more podcasts do you have? That's a dangerous question to ask with only 27 minutes left, Ken. So I'll tell you what I told the ASAP group when I was presenting this morning. A lot of people have two really important points, I think. Right now, we have $100 million or so MTM industry out there, right? That's peanuts in healthcare, right? That's a lot of money on Pinterest, okay? Not healthcare. The denominator in healthcare is $3.6 trillion, 3.6 million millions. All right. If you're not into the billions, you're not even relevant. Okay. We need to focus as an industry of going from 100 million, right, to somewhere between 10 and 50 or more billion, right? So 50 billion is 50,000 million. Now we're talking about real funding, real systems, right? So we have this focus on, can I be a quarter or a half of a grape from a technology perspective, right? Versus there's a whole watermelon over here that we're not even playing in that arena, right? So we have to get into the watermelon, not just for the IT industry part of it, but for the provider part of it, right? And the other thing I would say that folks just getting new into this concept from our typical pharmacy world need to understand is that it's not, what we do is we kind of do this vendor way of doing things right now. Even CPESN is a vendor within the payer systems where we go through these weird, I've seen what kind of auditing, privacy, security, contracting looks like on the primary care side, because they say, oh, this is a group of providers, here's our contracting, here's our people. We always end up on the vendor side, or 98% of the time, because that's what they're used to thinking. It's vendor, and that's not a knock on vendors. It's more just because of how the market sees us in pharmacy, and we got to change that. And the reason for that is when you look at medical, they bill 99214s, right, Pooja? They bill 992 whatevers, or they bill this, or if I'm my PT billed, I meet for 45 minutes, and there's 15 increments of 3 codes, and then it gets all adjudicated, and it's $88 after all the discounts and yada, yada, yada. That stuff's not gone away. That stuff's not going to go away for a while. It doesn't mean they're not doing value-based contracting. Okay? So I was on another call this morning, Oregon, you can bill smoking cessation for it. Oh, are you worried that this isn't part of a value-based contract? No, we need as many of those as possible. The value-based contracting part comes out after, right? Where you go to the payer and you say, hey, you billed us for 100 codes. How many were successfully weaned off cigarettes? And if that's 30%, guess what? We'll double your rate, or we'll provide a bonus. That's what value-based contracting is. You got to have a base. You got to have a base thing that you're like, I provide a service, I get something for it. Otherwise, what you're talking about is we're going to have a pharmacy HMO. No, right? That's what HMOs do. You're always going to have some kind of, you did a service, I pay you for it upfront in some way because there's not a lot of capital. Then you're going to wrap around how well you do, or what the financial vehicle or the risk or the reward is around that payment for the service. And so I think there's some naivete out there about, well, it's just all going to be value-based arrangement. No. You have to still win the provider status or whatever battle. You have to get paid for the service at its core. The value-based part comes with how it is you incentivize or disincentivize or discriminate payment for the provision of those services. So we got to go from a grape to a watermelon and get into medical side, right? Stuff, A1C, blood pressure, whatever else. And that we still have to get to the point where we can bill for a service. We're not going to just jump straight to capitation, right?
Pooja, there was a lot there in Troy's response. Your thoughts about pharmacy and value-based care and who's going to prosper in this new world?
Yeah, well, I'll pick up on that farm or the provider status thread, because I think that's really important. And I know there was legislation introduced last year, and you would think just with the changes with the impact of COVID, right, and seeing what role pharmacists are playing, I know they're trying to introduce legislation again at the federal level. Some states, right, like providers are or pharmacists are recognized as providers, but until we get it, I think at that federal level and allow pharmacists to be able to charge for their services, it is kind of, that's something that I think is a huge barrier to all of this. And I think that's a really important thread that, again, I don't know if people recognize that, right? People hear, yeah, pharmacists are trying to get provider status, but when you unpack the reason why, that is a really important piece of this. And I think that's something that, for our listeners, if any, you take away anything from this, that's, kind of watch that, because that's really important for all of this to really start moving down the road of how we want to be able to see this working.
And at a fundamental level for pharmacy, community pharmacy at least, I'm not a fan myself of provider status. I don't think that's the right moniker. I provide a service as a community pharmacy, and I don't get paid for it as a service. Historically, it's a service that we're supposed to provide as a dispensing fee. Well, 2 problems with that. I've seen dispensing fees of 65 cents. That's not a service. That's not even a coffee. Okay, right? And 2, we can contort all we like. Paying for a service at a prescription fill level doesn't make any sense at all, full stop. So to me, it's more just about sort of framing it as, look, I've been doing services all this time. Increasingly, I've been getting paid less for it. Here's a better way to pay me in the pharmacy. That's to me, that's the way you frame it. And otherwise, services will stop. And the whole, the music stops, essentially, right? And so, just pay me a different way, right? Is what I'm what I'm saying, more than anything else, right? And so if you pay me a different way, I'm more than happy to engage in value-based contracting and make sure you get what you need, but you got to pay me in a different way. And not for each prescription fill, right? You're not going to pay me 6 times when I fill 6 prescriptions, right? You're going to pay me for a service when I provide a service. So fine, don't pay me over there anymore in the fills, because that's a dumb way to do it anyways, right? Pay me a different way, provider status, whatever. There's a lot of entanglement we run into when we say it that way.
So I've got a question queued up here that I think we've addressed quite a bit already about how the money flows in healthcare, how that's changing over the decades, and what it means for pharmacies that you represent and serve. As we were prepping for this call, we were discussing this game Blockus, where every player tries to take over the board. What are your comments here, Troy, about how this market is evolving from a financial perspective?
Thing number one, if you've never, I'm not a paid advertiser or spokesperson for Blockus, but it's a great family game because kind of anybody can kind of do it, and it's simple, and it's a great family game. And if you're not familiar, go get familiar with it. It's the best Harvard Business Review that you'll ever have, strategy MBA kind of review that you'll have, that you don't have to read a single word. And the basis of the parable is, to cut to the chase so that you're the best player when you open it new, is, there's a set of number of pieces that you have to get on a board, but you can't touch the sides of your own pieces. So the whole goal of the game is to get your pieces down on the board as much as you can before you can't play any more pieces. And the name, connivingly, mischievously, leads you astray by thinking the best strategy is to try to protect your space on the board. I'm going to use my blocks to block other people from being able to come into my space so I can play all my blocks. But the trick is, there's not enough spaces in your corner of the world to play all your blocks. And that's what's going on in pharmacy right now. There is not enough money in dispensing. Okay? Stat for you. 50% of the drug cost now is 2% of the fills. 3 years from now, that could be as much as 80% of the drug costs. 3 to 5 years, 80% of the drug costs are 3 to 4% of the fills. There's not enough space where you're at, right, to survive. So what do? The key to Blockus is actually to penetrate other people's defenses. That's how you win at Blockus every single time. So go play the game, and you'll just get an intuitive sense like, this really does make sense as I'm thinking about my business strategy in healthcare. Trust me.
Oh, gee, it's a little scary when you think about what that could do to the family dynamics.
It is, because there's who you and how you, like, who is it? Whose territory am I going to invade? Is it my wife? Is it my 14-year-old daughter? Is it, so it is true, actually. Yeah, because you can pick on people too.
Pooja?
Yeah, honestly, I never heard of the game before we were prepping for this, and I'm actually excited. I ordered it actually on Amazon. And I'm kind of wishing I had it when we were really quarantined, because it would have been a great game to play. But no, I think it's pretty much just echoing what Troy said. I mean, I think as in the pharmacy industry, we've got to be thinking outside of the box, right, and outside of your space, and there's going to be, I think we are set up right now to be in a position to kind of change things in pharmacy. I hear ONC, I hear CMS, I see them starting to focus on pharmacy and in that arena, but I think the real question is how do you make sure that you can stay as a viable business in the pharmacy world? How do you make sure that you're starting to, collect this data? How do we make sure that pharmacists are starting to get paid for their services? And I think there's just a whole thing around this, and kind of bringing it back to standards and transactions. There's a lot of things happening right now, and between the e-care plans, between being able to do more around specialty enrollment, being able to do a lot more in pharmacy, we need to start thinking more broadly. And I think we need to start working more directly with the payers and with, O&C and others to figure out, how pharmacy is actually going to play in kind of this new world that we're entering, which I'm excited about. I think things are hopefully we're going to see a shift now. I think the time is right.
If I use NCPA Digest math and sort of math that's publicly available out there, again, 20% gross margin, product margin, whatever else operating. There's different ways of saying it in pharmacy world, but at the end of the day, just the mathematical way of saying this is people are operating on anywhere from, scary to say it, -1, -0.5% to up to 2% profits, right? So let's say 1.5 is the average right now. Okay. So if you're a $10 million a year gross pharmacy, which is a pretty successful pharmacy, I've worked in 120 pharmacies as a floater. I bet only 5 of them were $20 million plus a year because specialties somewhere else, right? And so $10 million is a successful pharmacy. What's 1.5% of 10 million? 150,000. You're going to run a $10 million business, and that's you better be a $100 billion industry if you're going to have a 1.5% margin, right? So do the math. Okay, 150 that way with a ton of risk, ton of carry costs, a lot of operations, right? Or I can have a $1 million business with a 40% gross and a 15% profit margin or a 20% profit margin. What's 20% of $1 million? It's already more than your 1.5% of 10 million, gang, right? Services industries average 40% margin. And I see almost identical numbers on the healthcare side when you actually have economy of scale services. 71% of the profit margin at RX Clinic Pharmacy is from services, not 71% of gross, 71% of profits. And so pharmacy has to understand that shift. It's not about what you bring in, it's about what you bring in that you can actually keep after everything's been spent. And services are absolutely it. And COVID has provided a craft beer moment or hard seltzer moment to opportunity for pharmacies. And what I mean by that is we can say it to ourselves all day long. We can publish 58 trillion studies that say we do great things. At the end of the day, it's about consumers and purchasers, whether it's the patient, the taxpayer, the employer, the plan, the premium holder, whatever, it's those folks that matter. And what COVID perhaps has done is change people's mindset about pharmacies being providers of care. And so if that's the case and the consumer sentiment has changed, now it is we've got to get on our horses and actually execute on it. I keep pointing to the PQS Pharmacy Quality Solutions Trend Report. Great, amazing data in there. If I was a consultant, I'd be trotting out that data to every client I had, Pooja and Ken, right? One of the data points that's in there, it asks plans. If you had the ability to collect A1C and blood pressure biometrics from pharmacies in a structured way that allowed you to get credit for it, would you contract with pharmacies? And 3/4 of plans say yes. What I've seen happen over the last 5 years is plans have gone from the farthest behind on medical side, watermelon, bigger industry value-based contracting, to actually being ahead. And now they're the most ready. The providers are the next most ready, and pharmacy IT is the one that's lagging behind. From a workflow, submission of data, interaction, exchange to do what medical does. It's actually IT that's behind. The plans have leapt everybody and said, hey, what do I care where I get an A1C from? And if I can get it from pharmacies, are you kidding me? The ones the patients are in front of all the time, where we're going to be doing all of our testing, where we're going to be doing all of this stuff, where consumers like the convenience and all the stuff we've been talking about, that kind of stuff's really game changing.
Okay, as we work towards wrapping up this podcast, I'd like to ask you, Troy, is there anything you'd like to ask the industry and our listeners in terms of actions to take?
Two things. Thing number one is I'm on a mission to communicate to the world that we need some sort of consensus-based entity like PQA to step up or be created around pharmacy information technology to really enable the services billing and the value-based contracting, because the marketplace may get ready for it, but the cost to administer services, payment to pharmacies, the cost to administer value-based contracting from a friction, administration, all of that stuff is too much to be the watermelon. That's why it's still a grape, frankly, okay? And then second, so what's the consensus? Where's the compass? How are we getting together as an industry and saying, here's the key 3 capabilities that a pharmacy user interface needs. Here are the 3 transaction capabilities. What's the relay health of services, the MD-on of services, the switch, what does that look like? Where's the compass so that the industry can move forward quickly? I don't know what that is. I hope somebody steps up. The second thing is pay us differently. I'm not going to say the P word, as we discussed earlier, but that has to happen. Our associations need to make that happen. We need to make that happen. We need plans to make it happen. We need advocates. And I don't think it's more research that says we can do it. It's going out to the consumers and saying, you're at harm unless pharmacies get paid for services and pharmacists get paid for services, you are likely to be harmed. That's how every other person gets paid in the system. You're missing out. You don't get a service that you need. We've established we can do it well and do it right and all those sorts of things. We have way too much emphasis on that.
Pooja, take us out with final comment.
Sure. So I love Troy's idea of kind of someone stepping up, right, and doing the consensus building around, the services billing and the pharmacy technology. I mean, we talk internally all the time about how we need almost like a Da Vinci accelerator for pharmacy now, right? I mean, get the people in the room who care about this stuff, who we come up with the use cases, figure out what we need to do, and build that consensus around what do we need? What does this look like? I mean, I think there's a lot of the groundwork has been done now. So now we need to get those people in a room, step up and get that moving. So I'm all for a pharmacy accelerator, group to do this. So I think, just kind of wrapping up from my side, I'm really excited that, we got to have Troy on. I think, pharmacy, I think the day is coming now that we're ready for this, and we just need to get those stakeholders together, get some consensus and get things moving forward. So just excited to hear kind of Troy's take on all of this, and I'm in agreement. I mean, I think we just need to now take that next step forward around all this.
Okay, great. I want to thank my co-host, Pooja Babbrah, and especially thank our distinguished guest, Troy Trygstad, Executive Director of CPESN. Thanks to our audience for listening to this edition of Point of Care Partners, The Dish on Health IT. Please follow us on Apple Podcasts, Spotify, or whatever platform you're using to pick up your podcasts, including our most recent new platforms that just started carrying us, Healthcare Now Radio and the podcast channel. And if you prefer, you could also watch extended versions of our podcast on the POCP video channel, which is on our website. And remember that Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interoperoutlook@pocp.com to learn more about our new Interoperability Outlook subscription monitoring service.